Chad, thank you so much for being with us today. I really appreciate it. I can see you're coming from your car here in Phoenix,
Yes.
Arizona, so we don't want to have any, if it gets too hot, please let me know and we'll stop and get you rehydrated.
Absolutely. Thank you for having me. Appreciate it.
Oh, thanks again for being here. So you're a nurse anesthetist and you have quite a bit of experience treating patients who are undergoing hip replacement surgery. What I'd like to talk to you about today is if you could just walk us through your approach to that and how things go, we would really appreciate it.
Absolutely. It'd be my pleasure.
Now, the first thing that happens is you meet the patient. Can you tell me about that? What's that like? What are you looking to find out? What kind of questions do you ask? And what are you looking for in that encounter?
Absolutely. I find it's actually interesting for anesthesia. We have a very short period and a window of time that we need to connect with our patients, gain their trust, and explain them and allow them to put their lives in our hands in a very short period of time. So in that time period, when we do talk to them, it's very important that we greet the patient, we're respectful of them, we're respectful of their medical history, their concerns, their questions, that we answer everything as thoroughly as possible. Primarily, most of the things that we do look for, are common things like allergies, the food or medications. We also look for any previous problems with anesthesia in the past. Many people have had certain kinds of anesthesia that may not understand all types of anesthesia, but we do our best to explain exactly how we're going to handle their anesthesia so that they can basically ambulate as soon as possible after surgery and be able to leave in a quick amount of time.
Yeah, and ambulate here means get up and walk, and certainly crucial in the ambulatory surgery center. The only way out is to walk out, so they've got to wake up and go. We've just been so impressed with the patients you and your group have treated at Phoenix Spine and Joint. The patients just seem to wake up with almost zero pain and walk right away. It's just been wonderful. I understand the spinal anesthesia plays a big role in your success. Is that correct?
That is correct. It's been around for many, many years. The technique has changed for the better, definitely in the last decade or so. The medication has changed a little bit, but definitely the tools that we use have improved to have a better outcome for patients. So having a bad reaction to anesthesia 20, 30 years ago from a spinal nerve block is definitely probably going to be different this time around. But definitely, it's one of the best ways, and it actually is evidence-based, that spinal anesthesia is the preferred method of anesthesia for all joint replacement surgeries for hips and knees.
Boy, it's been dramatic in the experience at Phoenix Spine and Joint, the way people improve. Now, the spinal anesthetic is done in the operating room, though, right? It's not done in the preoperative area.
Absolutely.
So once you finish your interview with the patient, they're wheeled into the operating room, and they're going to get the spinal in there. What happens right when they get into the operating room?
So we try to give most people, some sort of IV relaxation medication. It's usually a benzodiazepine. It's a short-acting medication, but it definitely helps release and lessen the anxiety of having surgery. So typically we put that medicine through your IV as we take you back to the operating room. It works very, very quickly. Once we get you in the operating room, we do move you over to the operating bed. And at that point, everyone is out of the room except for myself and the nurse. And then we get you in a position where you happen to slouch, which is something that I always say that my wife ags me about all the time, that you don't slouch, you sit up straight. But this is the one chance you actually have to have bad posture. Typically, a spinal anesthetic takes maybe 30 seconds to a minute. It doesn't take very long. And most people do say that getting an IV or some other type of injection is much worse than doing a spinal block. We have the opportunity of numbing the skin before we do anything. And it typically, like I said, takes maybe 30 seconds. It's very, very quick. And after that point, which is nice about the spinal anesthetic and it's something that I explain to the patients in the preoperative area, is that we try really hard to not use any narcotics or IV opioids. We find that patients wake up feeling much better, much more awake. There's less incidence of nausea and sickness to your stomach. And the spinal anesthetic literally takes away all of your pain, feeling, sensation from about your belly button to your hip joints all the way down. And in that effect, it allows your body to rest basically under anesthesia while you're having surgery.
That's fantastic. And it's over before you know it, but that's not all the anesthesia you're going to get, right? You're going to be further sedated.
True. We typically use an IV anesthetic. It's called a TIVA, total IV anesthetic. It's the same concept as a general anesthetic in that we don't use any gas. It all goes through your IV. It's a medication called propofol. And what's nice about it is it works fast, which means that you go drift off to sleep in about 30 seconds. Body breathes naturally on its own. You're just in a nice, comfortable, deep sleep. And in that effect, you're actually going to wake up from anesthesia faster. It typically will wear out of your system within about 30, 45 minutes after surgery, but you really do wake up and start answering questions and looking around probably about 5 or 6 minutes after we get you to recovery.
I mean, 25 years ago when I started doing surgery, everybody was in the recovery room throwing up and just puking their guts out with the nausea from the general anesthetic. And even as we tried to prevent that, it was just a constant problem. We just don't see any of that with these patients now with the combination of or almost none of it, with the propofol and the spinal. So not having all that puking, oh my gosh, that's just an enormous benefit in my mind.
Absolutely, absolutely. We do overdo it probably with the anti-nausea medications just in case, because we know that these people are going to go home and we want them to be as comfortable as possible. And I know what it's like to be sick to your stomach and you don't want to do anything. So how can you heal and recover, if you're sick to your stomach or you're in pain? And so that spinal anesthetic, an important basis of that is that it does make your muscles completely numb so that you can't feel anything, but typically it wears off. It's a time-dependent medication, which means it takes time for it to wear off. Generally speaking, at least 2 hours, about an hour after surgery, that spinal medication is worn off. You're able to stand on your own 2 legs and you're able to walk around, and within a few minutes after that fact, you can actually go home.
Fantastic. Well, one of the great thing about the spinal is that it avoids the general anesthesia. And just for our viewers, general anesthesia is where a tube is placed in your throat and there's a ventilator which breathes for you, or the anesthesiologist breathes for you. But to get to that level of anesthesia requires sedation that is very, very deep, and that causes other problems. Can you tell us a little bit about that?
Definitely. So it's not that it's a terrible outcome, but it's definitely not the most optimal outcome of having general anesthesia versus the spinal block and the TIVA. General anesthetic does bring along its own risks. Like you had mentioned, just placing a breathing tube in somebody's windpipe can be risky. Not everyone's anatomy is the same. It also can increase your risk of what they call aspiration pneumonia, which is when whatever's in someone's stomach just happens to come up. It can actually happen when you place that breathing tube down into someone's windpipe. It doesn't happen to everyone, but it's a risk that can happen for sure. And then on top of that, the general anesthetic does include, you have to take away that pain. You don't want people to be uncomfortable, and that does require heavier IV narcotics and opioids. And those typical medications, they last longer, but they do also have a lot of negative side effects, the nausea, that kind of people complain of constipation. People are unable to urinate. And so sometimes we have to place a Foley catheter in those people. So definitely there are some other side effects that we do not have to experience by bypassing it and doing the spinal anesthetic along with the TIVA, the total IV anesthetic.
It's such a big deal. These anesthetic techniques that you guys are practicing today that have allowed patients to recover without tremendous nausea and get up and walk within an hour or two of surgery have had a big impact on the most feared complication of them all, which is the development of blood clots and embolization to the leg, to the lungs. About the only way to die, this is a very safe procedure, total hip replacement. About the only way to die is to get a blood clot, and the way you get a blood clot is by not getting up and moving. Your anesthetic is allowing people to do just that.
Absolutely, absolutely. Besides, relieving patients' pain and I always say that our anesthesia minimizes. I'm a minimalist when it comes to anesthesia. I don't like to give a lot of medications. I don't like to do a lot of things. I like to do a basic thing that's going to make it easier for both of us. But spinal anesthesia does that. It actually helps prevent blood clots. It actually helps reduce blood flow. It makes the surgery go easier because the muscles are relaxed. And those are big muscles that these surgeons are working on in the hips and in the knees. And they require muscle relaxation. If that's a general anesthetic, that's just another drug that I need to give and another drug I have to reverse. Versus the spinal medicine, it takes care of all of that basically in a nutshell. So absolutely, there are many, many benefits versus not conducive to having a spinal anesthetic.
Chad, spinal anesthesia has been practiced for many, many, many years, and it's a very safe technique. But one of the recognized complications is a cerebrospinal fluid leak, which can cause headaches. Is that common, uncommon? And when it happens, what do you do about it?
Right. So it is a very uncommon practice, specifically with the spinal anesthetic. The particular needles that we use tend to not damage the tissue that the old needles used to. And we actually use a very, very fine needle. I explain it as about as big as 3 or 4 of your hairs. So it's very, very flimsy. And that in effect, the needle itself reduces the effect of having a spinal leak. Using a bigger gauge needle can sometimes increase that incidence, multiple attempts. And also, using a very large needle, sometimes what laboring women have is when they have epidurals. An epidural needle will almost always cause it if for some reason you do puncture that dura. Whereas the spinal anesthetic, it's very, very rare that we do have those problems. If it does happen, usually you can use a conservative technique, where you hydrate yourself as much as possible. Using caffeine is a really good one. There's 2 alternative methods for invasively and kind of less invasive treatment. The less invasive treatment is actually called a I'm going to have to remember what it is. It's like a TPA block, where we actually put some numbing medication backside of the nose. And what it does is actually we use it sometimes for women that have migraine headaches. And it just takes a few minutes. It doesn't take long, but it's kind of a less invasive way to do it. But most people don't like getting a Q-tip stuck in their nose. So therefore, the ultimate treatment would be something what we call a blood patch. And that's where we would take blood from the vein that's from the patient, and we would actually administer that through an epidural needle into that space, the same space where we place that spinal block. It's very invasive, but it does treat it, and it has a 90% success rate. It does work very well in curing that spinal headache. But like I said, there are some other less invasive techniques to help prevent that from happening. But again, our spinal needles nowadays, it's pretty rare that you actually see that side effect.
So unlikely that it's going to happen. And if it does, we've got it covered.
Yeah, absolutely.
Wonderful.
We'll take care of it.
Thank you.
Yeah, of course. Thank you.
Well, Chad, I just can't thank you enough for being with us today. It is summer here in Phoenix, and I'm starting to worry that you're going to pass out in the car.
It feels good. I'm quite all right. I actually look forward to getting into walking outside after being in a cold OR usually.
No, they are.
I don't mind walking out with that.
Well, have a wonderful day, and thank you again so much for taking the time to be with us.
No, it's my pleasure. Thank you.